workshop, meeting and webinar today for the MIGS workshop, which is being conducted for the first time in YOSICon 2026, for which we are very thankful to our governing council, led by our president, Dr. Devakant Mishra sir, our immediate incoming president and the vice president, Dr. Karan Bhatia sir, immediate past president, Dr. Sonal Kalia ma'am, our secretary, Dr. Nilesh Kumar, our joint secretary, Dr. Prasanna Ramesh, and our treasurer, Dr. Aditya Sethi. And this entire thing has been put together for you by the glaucoma focus group team, and I happen to be part of it. I'm Dr. Arshi Singh, and a lot of this work has been done by Dr. Shivam Gupta, who's leading from the front, and the other members who are as much a part, and you'll be meeting them all in person at YOSICon 2026. I would absolutely give a hearty round of applause to the entire glaucoma focus team for working very hard to bring this about. So our webinar today is actually to start your journey into MIGS, to show you a roadmap, and who best to lead you into this journey than our very own Dr. Madhavi. So Dr. Madhavi will be taking a class for you, but before that, I want to tell you a brief overview of what the Glaucoma Focus Group for YOSI does. So we actually have a WhatsApp group known as the Glaucoma Interest Group. Now, this is the QR code. You can please join it. This is free for all members. And what we do is we actually have a Thursday trivia week in which we discuss a question sometimes, or just a point or a case. And that is something that you have a discussion about, and people come forward with their points. People can also discuss their own doubts about their own cases. You also have what's new in glaucoma. Sometimes we discuss about what the newest reports are, what the newest studies are. And on most Sundays, we try and post up a glaucoma unscrambled. We have a different team that takes care of this, and the unscramble is usually of a glaucoma topic, and there's a discussion about that as well. So that's something that we do for the academics. And besides that, every World Glaucoma Week and every other time, we keep having webinars, and we have posted a few relevant content on YouTube, and we also encourage art we have coordinated, and we have also we've worked together with the YOSI cultural group led by Dr. Nupur Goel ma'am, and we have come together with a lot of Glaucoma Week webinars because of this, a lot of them led by Dr. Nupur Goel ma'am and her brainchild. And these are the few of the activities that we've conducted over the past 2 years. This group is just 2 years old, but we are steadily increasing, and we would love your input and your membership for this. So also we've got recognition from the Glaucoma Society of India. They gave us our own session during the last Glaucoma Society of India conference known as the Glaucotal, and we had a next gen GSI session. We had a lot of new speakers, all of them young ophthalmologists who spoke over there, and we had a very good panel discussion. We also were able to conduct a winter surgical carnival at Dehradun, and this was all because of Dr. Shivam Gupta's efforts, and this was very well attended. And we also had a MIGS workshop over there. These are a few glimpses about the workshops. We had academics, we had a fun-filled cultural night. This is what the session looked like, and this is what your session also would be like, and probably a little more to it as well. And patients were there, people were there, and we had hands-on sessions and a lot of learning. So now I would like to invite our governing council, Dr. Devakant sir, Dr. Karan Bhatia sir, and Dr. Prasanna to say a few words before we move on to the presentation by Dr. Madhavi ma'am.
Yes, thank you, Arshi. Can you hear me?
Yes, sir.
Yeah, perfect. So, welcome all of you to MIGS Shala. I think it's a one-of-a-kind event that is being conducted first time in YOSICon. And we are very happy to see the response. I think this has been one of the most popular workshops that we've been had the opportunity to conduct. And I've seen that a lot of people from other specialities have also shown interest. And personally, I also wanted to do it, but I thought I would not commit myself to a workshop. Probably next year I'll do it. And I'm so happy that the glaucoma focus group is working so hard. When I took over as president and we thought that we'll start a specialty focus group, we were not very sure how things would turn out. But we had such an energetic team that worked so well. And the WhatsApp group, I always see it so vibrant. And now the MIGS Shala that we are doing, The whole team has worked tirelessly for this. I hope everybody takes benefit. This is still a new modality for a lot of us, and workshops like these will definitely help uh, to help us in our careers, and of course help our patients with these new things. So I welcome all the participants of the workshop. The whole glaucoma focus group team is here. I hope after the workshop also all of these guys will be there for you. I'm sure once a workshop cannot be enough, obviously there'll be a lot of learnings that will be there, and I think all of us are learning. Those who are doing also, they keep upgrading what they're learning, so it'll be a lifetime of association that we are trying to form through this workshop. And let's connect, and as she said, we hope to meet all of you during YosiCon. Please come and say a hi. It will be good to chat up with everybody. So best wishes, and thank you, Dr. Madhavi ma'am, for taking out time and helping us with this workshop. So over to Arshi, and thank you and best of luck.
Thank you so much, sir. Over to Dr. Karan Bhatia, sir, for his comments, please.
So I'm very looking forward to this program. In fact, Madhvi ma'am, I was the first person to register for this, pay and register for this. So so looking forward, and I would say this on behalf of the participants here, the people who want to learn, is that we want to become MIGS surgeons like all of you there, and all the best.
Thank you so much, sir. Dr. Prasanna Venkatesh Ramesh, sir,
Thank
is
you.
the... Yes, sir, please.
Thank you, Arshi, for this wonderful initiative. I think most of the activities that the Glaucoma Focus Group brought out in this tenure, as Dr. Devakan sir was telling, standalone sessions in the National Congress of GSI and the Dehradun wet lab that Shivam did, gave a lot of idea as to how MIGS is still reaching out in terms of a lot of people that who are really want to do MIGS, and how we can reach out to more people. So I remember having this conversation with both of you that we'll touch 25 registrations, and then there was a point where 2 days back we were discussing. I was telling to push to 100, and then Shivam and Arshi sir, 60 will be a good number. We'll do justice to the role. So I think we kind of surprised ourselves, but that's the quality of the course that is being planned, and a paid course having this kind of demand. It's very humbling, and to have our incoming president, Dr. Karan, on the next day of the forms, he called me and he told, "Please send me the link." I thought he's going to ask for some of his friends, and then he told, "I have paid." I'm like, these are what YOSI stands for, the setting up of precedents. He could have easily told, "Yeah, I am the incoming president," but that is what YOSI did, and as he started, then I think we had to end the thing at 60 or 70. Otherwise, we would have easily touched 100. So thank you to Devakan sir, Karan, Milesh, Aditya again, who's taking care of all the treasury or behind the wet lab. And with that, Dr. Madhavi ma'am, I personally started doing suture gat after one of the debates from her. So Shivam was who we wanted to have it. We always wanted Dr. Madhavi ma'am, because after that only I started my own mixed training program. So thank you, ma'am, for being here for YOSI, and Arshi and Shivam, even Dr. Varsha, and the whole gig group is leaving no stone unturned in this YOSICon, and looking forward to seeing you all as well as our international colleagues. I can see so much people joining this meeting. Jerusha, Dr. Jerusha from South Africa, Dr. Amit is here. I think that's the impact MIGS is creating. From Nepal, we have Amit, and so many people very, very interested to learn. I can see my senior, Dr. Chinmay. So looking forward to learning from you, ma'am. Again, the learning never stops. Over to Arshi and Shivam to take the torch forward. Right.
Thank you so much, sir. So I will again repeat what sir said. A lot of hard work has gone behind scenes, and you will see most of these people in person during YOSICon, but they deserve a acknowledgement and, again, as I said, a big round of applause from all of us for working so hard. So our glaucoma focus team is Dr. Achal Singhal, Dr. Megha Ji, Dr. Neha Midha, Dr. Prasanna as an honorary member, Dr. Reenal Pandit, who actually helped us start the glaucoma focus group WhatsApp group, and Dr. Shivam Gupta, who's been working extremely hard and showing a lot of talent over here, Dr. Shweta, Dr. Teki Dodamkara, Dr. Varsha Ji Bilamgi, who basically takes care along with Dr. Shweta and Dr. Nidhi, as well as Dr. Kavya, who joined us recently for the Glaucoma Unscramble on Sundays, and also Dr. Virender Bagrania. I thank the entire glaucoma focus team once again, and you will again, as I said, meet all of us in YOSICon. And now to introduce our most honorary Dr. Madhavi ma'am. Dr. Madhavi ma'am is a DNB ophthalmology, MNAMS, and fellow of Arvind Eye Hospital in surgical glaucoma. She's the clinical head of cataract and glaucoma services at the Eye Foundation, Vellore, Tamil Nadu. Ma'am did her MBBS from KMC Bangalore and thereafter did her ophthalmology training and glaucoma training at Arvind Eye Hospital. She's had multiple awards to her name. You can see so many of them. She's been an international hero. She has multiple instruction course videos, and she's so humble. And again, ma'am, I wish you were coming to YOSICon because everyone would have loved to meet you. But right now, at least your virtual presence is here. And thank you so much for teaching our participants today. I'm sure they will have a wonderful time learning with you. I'll stop sharing, ma'am. You can please take over now.
And thank you, Dr. Ashi, for the kind words. So it is my honor and privilege to be here. And thanks to the entire YOSI governing team for giving me this opportunity. Especially, I would like to take a moment for the wonderful work the glaucoma focus group is doing. I hope my screen is visible.
Yes, ma'am.
Okay. So before starting the topic as such, as Dr. Prasanna pointed out, when we started minimally invasive glaucoma surgery, there were hardly any structured courses to start our journey of MIGS. So what we essentially did was discuss among ourselves and what to say, just moderate and the procedures we did along the way by discussions only and sharing our videos and tips via WhatsApp. That is how we started our MIGS journey. And in fact, I was one of the privileged. Why I call myself privileged? Because 2 years I was mentored by Dr. Devendra Maheshwari sir. Not everyone will get a privilege to have a mentor like that. So, for those people who want to start minimally invasive glaucoma surgery, programs like this, I'm hats off to YOSICon 2026 for coming up with such a wonderful idea, because this is how one can essentially start their MIGS journey through these structured courses. This is a very good starting point for all of you. So, without much ado, let me jump to the topic. So today I'll be speaking on minimally invasive glaucoma surgery roadmap, how to navigate the basics of these surgery. So modern day glaucoma surgery looks something like this. When you see this slide, you can see how complex the surgical procedures have become. Like the options are many, too much in fact. So let me simplify it a further bit. Why is there a need for minimally invasive glaucoma surgery? Definition, classification, approaches, and a bit of anatomy and physiology. More or less, I'll be speaking on how to start the mixed procedures. So we know that glaucoma is the leading cause of irreversible blindness, and mind you, it is going to reach a whopping 111 million. And already 4.5 million people are blind globally due to glaucoma. So when we classify the treatment modalities, it is very simple. Either it is medications, lasers, or surgical procedures. So when we talk about the surgical procedures, there was a therapeutic gap between the trabeculectomy and the medications and lasers. So this is where the concept of interventional glaucoma came into being. With minimally invasive glaucoma surgery once introduced, it offered a better safety profile, faster recovery, and in terms of improved quality of life for the patients and a sustained intraocular pressure control. That is where the essentially the importance of MIGS lies, because it managed to fill this therapeutic gap. Now it is doing much more than filling up the gap. So the definition of MIGS came Mind you, it came in 2012. And this person, Dr. Iqbal Aik Ahmed, who came up with this definition, and it has 5 characteristics: high safety profile, it uses an ab interno approach, and it is easy for use of surgeons as well as patients, with a meaningful IOP lowering and with minimal disruption of the anatomy. So you can see that trabectome was one of the earliest MIGS procedures, and it was introduced just before 2004, 2005 that time. Then came the iStent, and somewhere in 2014 came the GAT, and followed by KDB, and then onwards there was an array of procedures which came in the mixed armamentarium. So let's simplify it further. We can classify it into device-based MIGS and the non-device-based, that is the trabecular meshwork-based MIGS. So let's, in the device-based MIGS, you have the iStent and the Hydrus, which is available in India. So I have very simplified it much to the devices which are available in India, and the procedures that are being commonly done in our routine clinical practice. So for the non-device based or the trabecular meshwork based MIGs, you have the KDB goniotomy, the suture gap, bang, DDH trabeculotomy, and the microhook trabeculotomy. Either you can use a LAN microhook or a Tanito microhook. So these approaches, you can see that most of these approaches are targeting the trabecular meshwork. And some of the upcoming approaches like the microstents are targeting the suprachoroidal space also. CyPass is not available right now. It has been withdrawn from the market. And ECP targets the ciliary body. For the subconjunctival space, we have the Zengel stent. So essentially in today's topic, I'll be focusing on the TM-based procedures because that is going to be the focus of your workshop as well. For the TM-based MIGS procedures, essentially it targets the natural physiologic outflow pathway. So you know that the trabecular meshwork from the TM, it goes to the Schlemm's canal, collector channels, and the episcleral outflow pathway. So why this image is very important is because you know that for these procedures to work, the episcleral outflow pathway as well as the collector channels patency should be there. So that is something you should keep in mind before even thinking of doing a mixed procedure. Okay, so let's jump right ahead into the steps. So step 1, the surgeon should be well prepared. So you are going to start your mixed journey. So let's see how you can prepare. So first and foremost, it does not start in the OT, but it starts in the clinic. So doing a gonioscopy thoroughly. So you should be knowing your gonioscopy, identifying your structures even before thinking of starting the OT. So identify the structures properly in the clinic and identify your landmarks. And then you can move on to your intraoperative practice. So here you can see that the novice surgeon is just trying to touch this is a deeply pigmented trabecular meshwork. Here you can see not every TM will be like this. So here the surgeon is just moving the spatula. This is just a spatula and just moving the spatula and just trying to touch the trabecular meshwork. So this can be one of the ways to just start your mixed journey. So you can see that the view is also very crystal clear and there is a clear separation of the structures. So this is how the view should be. So once that surgeon has prepared for the view, next is your patient selection. This is very, very, very crucial. So select your first patient with good neck mobility because you're going to rotate the patient's head to a certain degree, which I'll touch upon next. And there should not be any head tremor. Select a good cooperative patient. You don't want to struggle in your OT. And last but not the least, the angle should be visible in the clinic. So for patient selection, these are some of the points I would like to highlight. So first and foremost, choose an open angle glaucoma. This goes without saying that you need to have a well opened angle so that you can do the procedure with ease. Next, choose a patient with mild to mild glaucoma. Don't even think about doing it in moderate glaucoma as the first case because you don't know how it is going to work in your hands because you are going to make some promise to the patient that I am going to do a MIGS procedure. The IOP is going to come down. So this is your first case. So choose a patient with mild glaucoma and always choose a patient who is going to get combined mix with phacoemulsification. Why I say that? Because the standalone mix, the results can be quite variable. So for your first case, always choose combined with phacoemulsification as the first case of yours. And this is another important point. When you are choosing your cases, don't go for angles with lighter trabecular meshwork pigmentation. As I previously pointed out, that gonioscopy in clinic is very important. So when you are choosing your case, even if it is lightly pigmented, sometimes you do the gonioscopy in the clinic. There you may be able to identify the trabecular meshwork. But once you're on table, if the pigmentation is very light, sometimes you may be having difficulty to identify the TM on table. So for your first case, choose angles with good TM pigmentation also. So next is the positioning. This is another very important step. For the patient positioning, you have this reverse Trendelenburg. Why? Because most of the MIGS cases will have the blood reflex. Only very few patients won't have the blood reflex, but this will essentially help you to do the procedure with ease by keeping the head above the heart. And what it actually does is to help the blood reflex from the Schlemm's canal. This may seem like a very insignificant step, but mind you, it is going to be very, very helpful when you are moving to procedures like suture GAT. Next is the surgeon and the microscope positioning. So here you can see that the patient's head is tilted 30 to 40 degree away from the surgeon and the microscope is tilted towards the surgeon. So the microscope is tilted towards the surgeon and the patient's head is tilted away from the surgeon. So this is the positioning where you are going to get an en-face view. And for the beginners or the experienced, this is one step I would like to highlight. Do the marking, because you are not going to do just a MIGS alone, but you are going to switch between the MIGS and the phaco. So have a microscope marking. So wherever I go and operate or whenever I am going and operating in a new theater, this is one of the first things I do. I make the marking, and you can use any apps which is available in your iPhone or even the other phones like Angle Meter, which can help you to make the marking at the 30 to 40 degree mark. So this will help you to make the transition easier between the phaco and the MIGS procedure. Next, know your instruments. So the gonioscope which we are using is the direct as well as the indirect gonioscope. So essentially we go for the direct gonioscope. So there are a lot of options you have it available, like the Hoskin-Bakken, the Swan Jacob, the Hill, Rich, Transcend, Wall Gonial lens. So whatever lens you choose, have a good practice with your gonioscope so that while starting the procedure, you find it rather easier. Personally, I love the view with the Swan Jacob. I don't have any disclosures, but I know Dr. Prasanna, who likes the Transcend Wall Gonial lens, because it comes with the stabilization rings. Here you can see the stabilization rings, which help you to manipulate the globe, especially while doing procedures like KDB. This is quite helpful. And some of the hands-free gonial lens can be also used in the initial cases so that you can have your left hand or the non-dominant hand free. So these are some of the other options which is available. So this is a gonio ready lens. It is a little bit expensive, but this can help you to do the bimanual MIGS. Like this is attached to the microscope. So flexibility is the key, and you can get wide access to the angles also. So this is gonio ready by Oculus. And this is not yet available in India, but once again, this is a little bit expensive. So as I said previously, there is a positioning which is required. That is a 30 to 40 degree tilt of the microscope as well as the patient's head, which puts the surgeon in a little bit awkward position. Your non-dominant hand will be away from you and your dominant hand will be towards you. I'll show you some pictures down the line. So this is one gonio, which is called the ocular straight gonio prism, which give you a static 45 degree view. So essentially what it means is that there is no need for microscope as well as the head tilt, and you can achieve a view in your primary phaco position itself. So these are some of the options available. So essentially you need a good direct gonio lens and a good high density viscoelastic. So those are going to be your weapons. Now that you have positioned your patient, you have positioned your microscope, let's look at the hand positioning. As I said, the hand positioning is also very essential for your optimal view. So this is the non-dominant hand, which is going to, unlike your phaco where both your hands are very close to your body, here you have to stretch your non-dominant hand away from you and your dominant hand will be closer to you. So this is the dominant hand and non-dominant hand. So this is how the docking of the gonio lens is done. So apply good amount of high density viscoelastics and then place the gonio lens gently, that is using the non-dominant hand. so that there won't be any undue pressure on the globe. So next, how to get a proper view. So when you're just placing the gonial lens, so here I'm just focusing without tilting the microscope or the patient's head, you're not going to see anything, right? So if there is no proper tilt that is going to be achieved, you will have an overlapping of the angle structures. So what we want is a en-face view. Here you are not seeing the view clearly because there is no proper tilting of the microscope as well as the patient's head. So you are seeing something brown, but there is no clear separation of the structure. So this is the top-down view. I'm sorry about that. I'll just reshare.
Okay, ma'am.
I think it is stuck. I'll just reshare, okay? Give me a second. Maybe you can have some questions or something.
Any
in
questions from anyone about the gonio lenses that you're using, about how you want to sterilize them? Any issues that you're facing in the tilts? People who've already started? If there are people who haven't started their journey yet, any things that you want to ask, especially about the microscope? Please post over here, or you can ask by switching on your audio. You're all part of the Zoom link so that you can ask your questions and clear your doubts.
And now it is visible again.
Yes, ma'am.
Yes, ma'am. We can see. You can share in full screen mode, ma'am.
Now?
Yes, madam.
Okay, so now what we want is a clear separation of the angle structure. So once you have achieved a proper tilt, that is when, so here you can see that the clear separation of the angle structures has happened. So that is how we want the en-face view to be. So getting the right view is everything to MIGS. So getting the right view is very crucial. So here I'm just having an unedited video. So tilting of the microscope is done, then tilting the patient's head is done. So when you place the gonio lens, you'll see somewhat of a grainy view. Then you have to use your left foot pedal and go to fine focusing so that you will get a good en-face view. Once you get a good en-face view, the procedure becomes very, very easy, be it any MIGS procedure. So apart from that, you have to identify the angle structures properly. Especially the scleral spur is a key landmark which helps you to identify the trabecular meshwork. So there is going to be, I'm not going to say that this is a very easy journey, but you are going to face a lot of hurdles along the way. So the narrow space, for example, you are a phacosurgeon, you will be used to a central anterior chamber depth of 2 to 3 millimeter. But know that the angle space is just around 0.77 millimeter. So the margin of error is going to be very less. So you need to be a master of intraoperative gonioscopy even before thinking of starting any MIGS procedure. And this is another thing. You are going to have a lot of intra and extraocular manipulation which are going to occur simultaneously. So essentially your left hand should be very stable and very gentle so that you could be doing the procedure with ease and not losing the optimal view as well. And this is another important thing because you are going to do at a very high magnification. So remember that you are not going to see the wound or what is happening inside the chamber when you are facing the angle. So here you can see that the instrumentation is very difficult because the view is at very high magnification. So what you can do is essentially zoom out and then lift the gonio a little bit and then introduce the instrument and then place the gonio. That is one way in which you can do it when you are working under high magnification. So this is going to be faced by anybody beginning the MIGS procedure. You are going to do, when you are going to do the procedure, your left hand definitely will give some folds. So consciously try to avoid any undue pressure in your non-dominant hand, so that there won't be any corneal folds which is going to impede your view when you are doing any MIGS procedure. And these bubbles, when you are doing the procedure, make sure that take out these bubbles, because initially you will think, okay, this bubble is not a small bubble which is not going to hamper my view. But when you are doing a procedure like 360-degree GAT, at some point, or when you are at the crucial point when you're trying to take out the suture, this bubble is going to trouble you. And bleeding, this is essentially the one of the biggest challenges that you are going to face when you are having the doing any MIGS procedure. So clear out your hyphema before even starting the MIGS procedure. And the 20-20-20 rule is something which my mentor, Dr. Devendra Maheshwari, tells all the fellows to practice. So before starting any procedure, practice 20 intraoperative gonio after your routine phacoemulsification. Just tilt the patient's head, tilt the microscope, and just see the structures. Just visualize. Don't even go in, just visualize. Use your left foot pedal. Do the fine tuning and the fine magnification, everything. So do all that for your first 20 cases. Then for the next 20 cases, just touch the trabecular meshwork and move the hand in such a way that your instruments are going to move. So you are now having 40 cases in your armor, so that next you can move on to your limited goniotomy procedure. So this may be a good procedures to start with, just as bent ab internal needle gonectomy or a tenito microhook trabeculotomy, which will put you at ease as a beginner, because you are not pressurized, because these are some very less expensive instruments, and you can start the procedure with ease. So these 60 cases are going to help you when you are going to handle something expensive like the eye stent or the hydra stent, or even a procedure with a very steep learning curve like a suture GAT. So this is one of the rules that my mentor used to teach the fellows and residents. So next step is the choice of MIGS. This is one of the very common questions that I get being asked. So what should I choose for this particular patient? So as I spoke before, there are non-device based TMX like the KDB goniotomy, the bent ab internal needle gonectomy, the microhook, the GAT, and now we have the indigenous Dave dual hook trabeculotomy also available in India. So these procedures are not new procedure, but they are time-tested techniques for congenital glaucoma. So what the difference is that these are excisional procedures or incisional procedures, but they use specialized instruments. So this avoids collateral damage to the Schlemm's canal when compared to the traditional goniotomy techniques. So hook dual blade goniotomy, one of the most common procedures that is being done in India. It is an excisional trabecular meshwork procedure which ensures the complete removal of the TM with minimum surrounding tissue damage. So this is how the KDB blade looks like. So you have a sharp tip which will penetrate your TM. Make sure that this ramp is going to lie parallel to the trabecular meshwork or the Schlemm's canal, and then settle the foot plate and then move it like KDB glide. The name is glide because you have to glide it along the Schlemm's canal. So this is a short video. So you can see this animation. So this is one of the techniques using the KDB glide goniotomy. So this is called the inside out technique. So in the inside out technique, so what you do is you essentially focus. So this is the earlier video I had shown, an edited video again. So you get a good proper en-face view before even introducing the KDB blade. So once you have got a proper en-face view, you can introduce the KDB blade by gently lifting the gonio. Here you can see I'm gently lifting the gonio. And then once you enter, go straight in and do one side. And then again go to that particular point and do the other side. So this is the inside out technique. Here you can see the beautiful posterior wall of the Schlemm's canal, that whitish structure. that is being marked. So that is how the cleft looks like. Then you have other techniques like the outside-in technique and the mark and meet technique. So mark and meet is like one point is marked and then you go to the other side and meet it. So that is the mark and meet technique. So here you are seeing the outside in technique. So you go to one end and come to the center. Go to the other end and once again come to the center. So these are various techniques in which you can do the KDB goniotomy. So now this is also very important because you're going to promise the patient something. So KDB offers an IOP reduction of 12 to 49% and approximately 75% of the patients were medication free. And mind you, KDB was one of the earlier introduced devices. So they have the 6-year results showing an average intraocular pressure reduction of 28% and AGM reduction of 30.8%. So next is the bent ab interno needle gonectomy, which is one of the very, very popular procedure among the novice surgeons because it is very inexpensive and it does not require any sophisticated instrument and it has a short learning curve and easy to perform. So essentially you just need a hypodermic 27 or a 25 gauge needle which is bent and it is fashioned, and mind you, you have to use the 5/8 inch needle because otherwise you are not going to reach the angle. So the bevel and the lumen is going to form the cutting agents. So essentially it is similar to the KDB goniotomy in the technique wise. It is very inexpensive and it is good for the beginners. But the studies in Bang are very limited. But we have 1-year outcomes from the Dr. Sushmita Kaushik ma'am. So it showed IOP reduction of 19.1% and AGM reduction of 69.2%. So one of the favorite procedures which I started my MIGS journey is the microhook trabeculotomy, which is a cleavage procedure. Why it was a favorite? Because it was like a Sinskey hook. So Sinskey hook is something which we are all used to as phaco surgeon. So it was a very sleek, slender instrument. So it was easy to handle. So we have a straight hook to incise the nasal angle. Also, you have a right and the left hook to incise the temporal angle. So it comes as a set of 3 instruments. And this is how the procedure looks. So you can see a beautiful pigmented trabecular meshwork. So as you move the Tenito microhook along, you can see the whitish structure that is the posterior wall of the Schlemm's canal. So a beautiful cleavage is being created by the Tenito microhook. So we have our own results from the early outcomes and the 2-year study as well, showing 42.6% reduction in the intraocular pressure and 70% of the patients were medication free. So this was a comparative study which compared phaco Tenito with the phaco group standalone phaco alone. And GAT is another very useful as well as a procedure which is a favorite of mine. 360 degree, it creates an ab interno trabeculotomy. It was described by Dr. Grover as early as 2018. So here the procedure is circumferential. Of course, the procedure has a steep learning curve, but the IOP reduction is something which is the most of all the mixed procedure put together. So the microcatheter assisted GAT was, it is very expensive because of the expense of the microcatheter. So we have come up with the 5-0-proline suture GAT, which is essentially the inexpensive version of the microcatheter GAT. So you can use a 5-0-proline or a 6-0-proline to do a circumferential trabeculotomy. So here I am using a 6-0-proline suture. And here you can see the trabecular meshwork is heavily pigmented. So this is an angle closure case. So I'm using a 6-0-proline. So once you do the goniotomy, see, you have to maintain, the key is maintaining the visualization at all time points. So once you are doing 20 to 40 cases of your limited goniotomy, the movement as well as maintaining the view, not at any point the left hand, that is the non-dominant hand, is giving pressure. So the view is maintained throughout, and then the procedure seems very easy when the view is maintained throughout. So multiple studies have shown that GAT has achieved larger and more sustained IOP reduction. Indian evidence is also promising both in open angle as well as juvenile open angle glaucoma. These are a series of our publications on GAT which you can go through. And yes, long-term outcomes are also there, which I'll come upon briefly. So this is the trabecular device-based MIGS, which is available in India. First is the eye stent, which is the small titanium stent. That is the trabecular meshwork bypass, which is implanted through the TM into the Schlemm's canal. So essentially, it creates a direct connection from anterior chamber into the Schlemm's canal. So this was the first generation eye stent, which is shaped like this and which should be inserted in a sideways fashion. Now what we have is the eye stent inject W, which is the third generation of the eye stent. So it has a wider flange that resides in the anterior chamber. So this was designed just to minimize the over implantation of the eye stent. So eye stent Infinite, which is not yet available in India, it comes up with 3 microscale wide flange stents on a single preloaded injector. The advantage is that it gives infinite clicks and you have to place these stents 2 clock hour apart. I'll show you a short video. So this is the eye stent inject W. So it comes with 2 microstents. And these stents, so these bleeding is normal. Okay, so this is a good sign. And you have to place it 2 clock hour apart. So eye stent is one of the earliest devices which came. So 8-year post-operative results are there. So IOP is reduced by 26%, medication use reduced by 17.9%, and the surgical success was reported to be 90%. Next is the recently, this has come into Indian market, that is the Hydrus microstent. So this has 3 windows and an inlet that sits in the anterior chamber. So it has a dual mechanism. So not only it bypasses the trabecular meshwork, but it creates a scaffold for the Schlemm's canal so that the patency is maintained. It is made up of nitinol, a flexible biocompatible titanium and nickel alloy. So I'll share a video once again by my mentor. So this is how the Hydrus microstent is primed. So initially you have to see whether the device is coming out properly before even trying to insert it into the Schlemm's canal. Then you gently insert and roll it inwards so that the device is placed. I'll show you once the device is placed properly. Now you can see that the device is properly placed in the Schlemm's canal. It should not be very opaque. That means it is deeply implanted. It should not be very visible transparently also. So this is how the proper implantation of the Hydrus is done. So Horizons trial is one of the landmark studies which came up with the Hydrus 5-year outcomes, which showed that 66% were medication free and 49.5% had IOP less than 18 millimeter mercury, and more than 52.2% had more than 20% IOP reduction. So essentially, Hydrus plus Phaco had good results when compared to Phaco alone. So this was a 5-year study. So to summarize all these, this is one of the favorite meta-analysis which came up recently in the American Journal of Ophthalmology. So it will give you an idea, because as long as there is no standard structured way to choose a mixed procedure, so these are the kind of meta-analysis I look onto. So control group is the phacoemulsification group. So you can see that the control group, that's the phacoemulsification alone, is going to give you this much amount of IOP reduction, that is 1.84. When you add a trabecular meshwork bypass procedure, this is the eye stent and the Hydrus, you are going to get an additional 3.33 millimeter mercury IOP reduction. When you are going on to non-GAT goniotomies, by this they mean the KDB or the bang, you are going to get a 5.24 millimeter reduction in intraocular pressure, and suture GAT in this particular meta-analysis shows that it is going to give the maximum IOP reduction. Similarly, you can see that the anti-glaucoma medication reduction with the TM bypass like the eye stent is minus 1.5 with the non-GAT, and with GAT is the maximum IGM reduction. So this is another interventional glaucoma consensus treatment protocol, because we have now a lot of procedures in our armamentarium. So there can be a lot of confusion. So for ocular hypertension, after lasers and pharmaceuticals, you can go for the tissue sparing mix before even attempting a maximal medical therapy. For mild glaucoma as well as the moderate glaucoma, the tissue sparing mix, then the non-tissue sparing mix before the maximal medical therapy, and last in the moderate glaucoma is your filtering surgery. Here in severe glaucoma, initially itself, we can think about the tissue sparing mix, bring down the medications, then you can go for the non-tissue sparing mix, and then maximal therapy, and last the filtering surgery. So this is a very, very basic consensus treatment protocol because there is not standard protocols available right now. So coming to our own indigenously developed Dave dual hook trabeculotomy. So it is a bidirectional dual microhook with a single handle instrument. What is the advantage of this instrument is that it is very economic and it reduces the need for multiple entries. So in one go, you can reach both ends of the canal and completes the trabeculotomy in one single time. So very easy for novice surgeons and beginners. So I'll just play a video of this. So here you can see the instrument going in. You can see there are two cutting edges on two sides. So you go on one side and do the trabeculotomy. And then without even taking out the instrument or refilling this chamber, this is an unedited video once again, you can go to the other side as well. So this essentially prevents you from doing multiple entries and you can complete the procedure in a single choice. Now once you can see the episcleral venous reflex happening. And now you can see the beautiful posterior wall of the Schlemm's canal. So every procedure has its own set of complications. Similarly, MIGS, though it has very minimal, it does comes with its own set of complications. So high FEMA is one of the most dreaded intraoperative as well as postoperative complication of any MIGS procedure. Rarely you can have iridodialysis and cyclodialysis cleft. But mind you, most of these complications, the Descemet's membrane detachment or the stent malpositioning, most of these complications in your initial stages occur due to improper visualization. So visualization is essentially the key. So for high FEMA, use generous amount of high density viscoelastic. Keep the eye pressurized. See here just a goniotomy is initialized and you can see the bleeding is so much. But once you have cleared off, there is no need to panic. Just fill the chamber. Keep on filling the chamber with high density viscoelastic. There is no need to rush the procedure because once you fill it with the high density viscoelastic, you can complete the procedure with ease. So high FEMA is not something that need to be feared, but to be cautious about. So to summarize, master phacoemulsification first. That will be the first and foremost step to your MIGS journey. So once you are a master at phaco, then preoperative and intraoperative gonioscopy. As I said previously, the journey starts in clinic, not in the operation theater. Then follow the 20-20 rule. You practice your intraoperative gonioscopy, touch the trabecula meshwork, then tear before even thinking of placing expensive stents or going out with a 360-degree suture gap. Wisely choose your patients. You choose a patient initially with a wide open angle with good trabecular meshwork pigmentation. Always go for a combined procedure. And last but not the least, choose the right procedure for your patient. So I would like to acknowledge my mentor, Dr. Devendra Maheshwari, and my team, Dr. Nimrata and Dr. Shivam, without whom this presentation would not be possible, and my current team at Eye Foundation Vellore also. I hope I was able to do justice to the topic, and thank you once again, Team YOSICON, for giving me this wonderful opportunity. I'm extremely glad to be a part of this program. Thank you once again. I'm happy to answer any questions you have.
Thank you, ma'am. Thank you for you came in on such a short notice and you have covered each and every points, ma'am. So we'll start with some doubts. I'll request Dr. Karan Bhatia, sir, to please ask his doubts. Sir, he has messaged something in group. Sir, are you available, sir?
I can't see Dr. Karan here.
Okay.
His question to you, ma'am, is for phacos for practicing intraoperative gonioscopy, do we need to give a block as we usually do not give blocks in most patients? And will the patient have pain if there's no block?
Yeah, for initial cases, when you're practicing your initial cases, you might be taking some time to do the gonioscopy because you're not going to get the view immediately you place the lens and you're going to be touching the entire cornea. So the patient is going to have some good amount of discomfort. So you can use a subtenon's block. No, I won't suggest any other block. Maybe give a little bit subconjunctival also if you are going to practice. But once you have mastered, like few cases you have already practiced your gonioscopy, then you will get the view the moment you place your gonioscopy. You won't have the struggle. So at least for initial 5 to 6 cases, even when you are just practicing, I would suggest a good anesthesia, because even when the patient is moving, you're not going to get a good view, especially the practicing part, the touching part, where the eye is not moving at all. So yes, that would be my answer. Shivam, anything you would like to add?
Shivam, the next question, please.
Ma'am, the next question is, how many clock hours do we need to treat? So this is from Dr. Sufian, sir. So what's your
Dr.
opinion?
Surya, you can also unmute yourself.
Again, it depends on patient you're going to choose it. As I said before, there is no consensus on how much angle you have to treat. But essentially speaking, 360-degree GAT has shown the maximum intraocular pressure reduction as well as the AGM reduction. It depends on what is the expected intraocular pressure reduction that you want for your patient.
The next question is, ma'am, what is the advantage of Tanito over KDB?
It is a reusable instrument, the first advantage. And second, for novice surgeons, as I said before, it is like a Sinsky hook and it is very slender. KDB, when you see, it is a little bit bigger than the Tanito's microhook. So it will be very easy for a novice surgeon to do a Tanito microhook trabeculotomy. Third thing, there is a difference between the way it does the goniotomy. Tanito microhook is essentially a cleaving procedure, whereas KDB goniotomy is an excising procedure. So that is a basic difference in the procedure as such.
Ma'am, another question is, please go ahead, sir.
Dr. Dipanshu, are you here?
Hello. Yes, ma'am.
Any questions from you?
Ma'am, I just asked that advantage of Benito over children.
Dr. Dhruv, you want to ask your question? What are the common beginner mistakes you have observed as a mentor?
Yes, the one of the common beginner mistake is the getting the right view. So you have to practice your left foot pedal also. That is a microscope foot pedal also. Try zooming in, zooming out. That is very, very, very crucial, because sometimes for phaco, when the trainees are doing the phaco, they are not used to using the microscope foot pedal. Rather, they'll go about using the table foot pedal, the operating table foot pedal. So essentially, you have to use the foot pedal, zooming in, zooming out, fine focus throughout. So, and then the pressure on the non-dominant hand. That is one of the very, very common mistakes that a beginner does. So relaxing your non-dominant hand is also very, very important. That you have to consciously do when you're doing any MIGS procedures.
Dr. Sampada, sir, your doubt, sir? Sir, you can unmute and ask, sir. So, ma'am, I'll just repeat his question. He's saying, he's asking, after MIGS, anti-glaucoma medication can be stopped entirely. So, what's your uptake on it, ma'am?
Yes, that again depends on the severity of the glaucoma. For moderate to advanced glaucoma, if the patient is on maximal medication therapy, I wouldn't stop all the medications in one go, especially in advanced. Maybe in moderate, if you're doing a suture GAT, you know that the pressure and the AGM is going to be reduced nicely. Those procedures you can stop. But in advanced glaucoma, one has to be very cautious when stopping the medications. But you have to stop when you want to know the actual efficacy of your MIGS procedure.
So, ma'am, there is a practical question asked by Dr. Savanthi. She's asking, can we stain the trabecular meshwork with trypan blue if we have difficult visualizing? So, I think so that's
Yeah.
something we all start, the beginner, we do, ma'am.
Yes, yes. That is one of the good ways to start when you are having a difficulty in visualizing the TM. But not every TM stains. That is also something you should be keeping in mind. The juvenile open angle glaucoma, those patients stain very beautifully when you are taking up for surgery. But once, even some of the very lightly pigmented TMs, sometimes it won't take up stain. So another easy way of identification would be to just decompress slightly so that the trabecular meshwork, the Schlemm's canal, will fill with blood. So that may be another way of identifying the trabecular meshwork in case your trypan blue staining has not taken up. Just decompress it slightly at the wound so that it will nicely fill up with the blood. Then you can once again pressurize with your high density viscoelastic and carry forward with the procedure.
Very useful trick, ma'am. Ma'am, Dr. Jerusha John has said, I usually sit at 12 o'clock but move temporally for angle procedures. I noticed in one of the pictures that the patient's right eye was being operated, but the surgeon was sitting on the patient's left. Is it because you want to access the temporal aspect of the angle in the right eye? I can imagine that is even trickier.
Yes, accessing other part of the angle, especially with the nose coming in the way, can be tricky, especially for tennito-microtrabeculotomy. As I said, we have the right and the left tennito-microhooks as well. So we used to move around and do the procedure so that maximum angle can be treated. But essentially, it is little tricky because when you are sitting on the patient's head end, you have to put the chin down to get a view. So essentially, you have to move it away from your visualization. Same holds good when you are moving around and doing the procedure.
Ma'am, Dr. Hemant wants to ask whether to do cataract before or after the mix procedure. So do you prefer removing the lens first or doing the mix first, ma'am?
I have done it both ways because, as I said, we did not have any structured programs at that point of time. But there are different views of thought on this. Some surgeons prefer to do the phaco first and then do the mix later, because the angle will be widened. So you have more space because you have already tackled the phaco part. And also, if you're good at phaco, it doesn't matter because there is going to be a lot of bleeding. If you're doing the MIGS first and then coming back to phaco, you are going to sometimes have trouble while doing your phaco. But if you're good at phaco, that doesn't matter. You can do the mix first and then do the phaco also. Why mix first is because the Schlemm's canal rigidity is still there when you're going before removing the lens. So that is one of the things why some surgeons do prefer to do the mix first. But essentially, for novice surgeons, for teaching fellows, I would say do the phaco first and then go to mix.
And Dr. Rupak
Okay,
sir is
ma'am.
asking to how to minimize.
Can we ask the participants to please unmute and you can ask your questions directly? It would be wonderful to hear your voice. Rupak sir, if you're here, can you talk to ma'am directly and ask your doubt? And in that sequence, as far as the chat box is concerned, you can keep going ahead and asking your questions. Rupak sir? All right, ma'am.
I
To
think
minimize
it is
intraoperative hyphema,
yeah.
how much time should we wait to proceed for visco wash and close the and hydrate the section?
There is a four-step process which is being described by Dr. Moideen sir, who is once again my mentor, which will be out in IGO soon. So it is the four steps include: first you have to wash out the hyphema first, then fill the chamber with air bubble and wait for 2 minutes. Then you can fill the pressurized chamber with 1.6% hyaluronate. Again, wait for 2 minutes. Then wash that out and then see how much the reflex is. And lastly, you can fill up with 1.4% sodium hyaluronate. Once again, this will come up soon in IGO. You can see the four-step process. But not for every case I follow the four-step process, because practically it is very difficult to have such a waiting time for the patients. So you can just wash out. And while washing, what I would suggest practically is keep an eye out for how much the intraoperative reflex is going to happen. According to the reflex, you can titrate your fill of the anterior chamber. So 20 to 30% fill is what is being suggested by Dr. Davinder Grover himself, depending on the blood reflex.
Dr. Aarti ma'am, you were asking one question.
Yeah. Ma'am, just before the head tilt, what were the steps? I missed out, sorry. Just
Yeah,
if you
so
can
that
brief.
yeah, that is how you start the procedure, the positioning of the patient, as well as the positioning of the microscope. So, what you can do is you can get the marking in the microscope done by using this apps, either an angle meter. So that will help you to switch between your phaco as well as the mixed procedures with ease. Then you can go on with your positioning.
Okay. Before that, only that step was mentioned, ma'am? Initial
Yeah,
10
yeah.
minutes?
Yeah, so essentially, I was just talking about the definition and things like that. I think it
Thank
will
you.
be recorded, right, Dr. Ashi? I think that will be provided.
Yes, ma'am. Yes, ma'am. We'll be giving, ma'am.
Yeah,
Oh,
yeah.
wow. Thanks a lot.
Dr. Tanvi, sir, can you unmute and ask your question, sir?
Hello.
Yes, sir, you're audible,
Ah,
sir.
Yes. Yes.
yeah,
Good evening, ma'am.
yeah.
Ma'am, I just wanted to ask, what is your tips on following up the patients of MIGS? Like, is it same as some other conventional trap surgeries and all, or is there something else that we should particularly look into when we are following up a patient of MIGS?
Yeah,
And about the
so
anti-glaucoma medications, ma'am, should we go for a concurrent medication also in the first, say, 3 to 6 months of follow-up if the IOP is not controlled, and keep following up the patient to see whether the mix is working or not properly.
So to answer your first question, when you are a beginner, you can keep a close watch on the patient because hyphema is going to be a biggest worry. So you can call the patient for 1 week follow-up and then titrate according to your results. So now once you know how your hands is going to work, then you can essentially call the patient for a 2 weeks follow-up 1 month as you do usually for your other glaucoma procedures also. To answer the second part of the question, so stopping anti-glaucoma medication. So mild, moderate glaucoma, when I'm doing a GAT, I essentially stop all the medications because that is how you know whether your procedure is going to work or not. But having said that, in advanced glaucoma, I would be cautious about stopping all the medications. Suppose the patient is on 4 medication, I would just stop 3 medications, keep the patient on a single medication, and call the patient for follow-up. Then once I know the pressure is stable, then I will even stop that medication. So there is another part to this question. There is something called intraocular pressure spike, which is very, very common with minimally invasive glaucoma surgery procedure. So you have to keep that in mind also before even thinking that your procedure has failed. So most often we'll think that because this is a new procedure and you are starting the procedure. So 1 week later, the patient comes up with an IOP spike because these are the kind of calls I will get usually. Ma'am, I did a MIGS procedure. Now the patient is 1 week follow-up. I don't think it worked. Now the patient is having 40 pressures. So what should I do? So you have to keep calm and be patient. Taper the steroids quickly or switch to a low potent steroid because steroid response and IOP spikes are very, very common in the initial period. And then after a month, still if the IOP has not come down, then you know that this is because of the failure of your procedure or your procedure is inadequate for that particular patient. So keep IOP spikes and steroid response also in mind before even jump starting or putting the patient again on medication. Because when you're doing mixed procedure, essentially you're promising the patient you are taking them off medication or you're going to reduce their IOP, right? So at least for 1 month, I would say keep a watch out for the IOP spikes as well as the steroid response. I hope
Okay,
that
ma'am.
answers your question.
Thank you, ma'am. Thank you.
I think next question is by Ashi. She was asking on pilocarpine, right? So pilocarpine, once again, it is a topic of debate. So many believe that there is no role for pilocarpine. And when I spoke to Dr. Ike about this, so he gives pilocarpine during his high stand, high dress for the first 2 weeks and sometimes even beyond that when he is going to expect more peripheral anterior synecdoche. But there is no strict consensus or protocol regarding pilocarpine use, and some very recent publications strongly advocate not using pilocarpine also. But having said that, practically speaking, we have been using pilocarpine in Arvind even up to a period of 1 month, depending on the either it is open angle or angle closure, we use it for a little bit longer period. So the dosage we use is BD for 2 weeks and OD for 2 weeks. That is practically speaking.
Thank you, ma'am. Ma'am, the next question is, what frequency of post-op steroids do you use?
So again, there is no standardized protocol for this. 6 times I start and taper it off, and I keep a watch for the steroid response and IOP spikes, which is very, very, very common. And most often, again, I have to reiterate this point because any beginner who jumpstarts the procedure and then call me in 1 week saying, ma'am, the IOPS, it even goes up to 40. So you get a lot of worried and stressed. Oh, I did the procedure. That was my first procedure. You are like, okay, I started MIGS, and then the pressure is not reduced. You feel like, oh God, this procedure has failed. But steroid response is very, very common.
Ma'am, again, so what is your high FEMA management strategies, and do you actually alter your pilocarpine use in such cases? When do you start your oral medications? What degree?
Okay, my threshold for taking up the patient for anterior chamber washout is very high. I don't take the patient immediately for washout. Only in 2 cases I take the patient for washout. One is the patient's vision is very poor. There is a full chamber high FEMA. That is the first occasion I take the patient for anterior chamber washout. So secondly, having said about washout, second thing you asked about the whether stopping the pylo and using the cycloplegics. Generally, I don't use the cycloplegic because usually the hyphema happens in day 3. Especially this is very common with suture gap when compared to other procedures. When the IOP, initially you are filling up the chamber with the viscoelastic, right? So for 2 to 3 days, it will be there. So it takes care of the hyphema at that point. By day 3, the patient is also very comfortable. So what I tell the patient is, by day 3, you'll be very comfortable, but don't do any heavy work. So that is something I make a point to tell the patient. So switching to cycloplegic, I generally don't do unless the patient is having very severe anterior chamber reaction and a large blood clot which is not resolving. That is when I go to cycloplegic and stopping the pilocarpine for that matter.
Ma'am, what is your opinion on high frequency deep sclerotomy?
I'm not very acquainted with that procedure, so I don't think I can give a valid comment on high frequency deep sclerotomy. Maybe anybody
And
else in
ma'am,
the panel.
your experience with ECP?
ECP also, I am not quite used to it. I think Dr. Prasanna is quite used to doing ECP. He's one of the proponents of ECP.
I think
Yes,
he's
it
going to
does.
tell us in person during the workshop, ma'am. Because
Yeah, he can tell.
Any
during
other questions from anyone? Use this opportunity to ask as many as you want. Ma'am is still a captive audience for us right now. In case no one posts in the next 1 minute, I'll give over to Dr. Shivam for the vote of thanks and Dr. Nilesh for his comments as well. Shivam?
Ma'am, I'll share the PPT.
Hello. Hello.
Yes, sir, you're audible, sir.
Yeah, I'm audible.
Yes, sir.
Yeah, just wanted to ask to start with first of our few cases. Should we prefer just the newly diagnosed cases or should we take up old follow-ups?
It can be either. It is not essentially that you have to take up newly diagnosed only. Only thing what I told why I told you to take mild glaucoma is just for the fact that you don't want to get disappointed, because I have seen many people starting
Yes.
MIGS and just abruptly stopping it, thinking that it is not working in their hands. So one thing to avoid surgeon's disappointment, second thing to avoid patient disappointment. So this is why I asked you to start with a mild glaucoma. So the patient expectation also will be that much only, because the patient might not be on medication, and you also won't get disappointed in your MIGS journey. So once you have moved past that stage, then you can take up any case you are comfortable, like what the patient warrants.
Yes. Thank you.
Yeah, how to sterilize gonioprism lens. So these Swan-Jacob Swan-Jacob lens is essentially autoclavable gonio lens that is available. So many of the autoclavable versions are available. There are other versions also which can be used for repeated use. Yeah, iPrism SX is also good. It is a good lens. But for essentially for GAT procedures, I like the view of person. It's a personal choice. Yeah, I mean, if you are used to any gonio prism, you can use any prism. But essentially for GAT, I love the view of the Swan-Jacob.
Shivam,
Yes, ma'am.
you can start sharing your screen now.
Yes, ma'am.
So we'll be taking you through what your workshop experience is going to be like and what you're going to be anticipating in the next coming 3 days for the workshop.
So first of all, thank you, ma'am. Thank you for coming and joining us and teaching us. You are sincerely you were the one who handheld me and taught me. So it's my duty to like give away this thing to others, and like they are still there huge load of glaucoma patient, huge load which we have to treat, and they are patients with mild and moderate glaucoma who have concurrent cataract who are going under cataract surgery. For such patient is really need MIGS is needed. I really thank the UC Governing Council, Dr. Devakant sir, Dr. Karan Bhatia sir, Dr. Sonal ma'am, Dr. Nilesh sir, and Dr. Prasanna sir, and Dr. Aditya Sethi sir for giving us this opportunity, this platform to bring the mix in the UC Con. I also very thankful to Dr. Shi ma'am, Dr. Prasanna sir, and the whole Glaucoma Focus Core team, which has been working for last few months on bringing this thing, and hopefully we have it a very nice presentation. So these are the slots which I have already shared. So what we have done is we have like restricted the slots from 60 minutes, so we have made it to 75 minutes so that you have enough ample amount of time to discuss your doubts, to discuss whatever small pointers you need, and you'll have enough like not more than 4 to 5 people in a slot, so that there is no overcrowding as usually there is seen in all wet labs. So this is already being shared with you. If anybody has any doubt, you can just come back and ask. So how it goes, first of all, there'll be a 15 minutes like orientation and a talk about what is it, what intraoperative gonioscopy is there. Then we'll divide you into three groups, like one in each station for around 15 to 20 minutes, in which you'll do first KDB or hydrous or iStent. Then you'll switch among yourselves about the how other the procedures. So that way you will have all 75 minutes of your time utilized in all these things. And of course, you can have one more thing which we'll be giving you is this. We'll giving like a small handbook, a beginner's guide to mix, in which there is some practical tips and tricks, like the main essential point which has to be done when you're starting your mix journey. Along with that, we are, as promised, we are giving like we want you to go back and start practicing your mix. So the main thing is, and main headache is procuring a gonio lens. So by end of the course, we'll be giving you one gonio lens to go back and start practicing. Along with that, this is a big surprise and a very big thing which we are still working on. And Prasanna sir has promised me that he'll getting his 4D hologram also, in which there'll be a like a 3D thing. You can wear it and you can practice there in the. So this is the first time we are doing such thing in any wet lab. And I'm just I'm just wishing Prasanna sir to bring this thing and this to be a great success. So once again, thank you, ma'am. Thank you. And this is our but the one WhatsApp group which we'll be continuing is the one which we have created now. Along with that, to discuss other glaucoma, small doubts and small queries which will come. So you can be anytime be part of this glaucoma focus group, glaucoma interest group. So you can scan and join the group. So with this, I'll stop sharing, and I'll request our General Secretary, Dr. Lee,
Our
sir,
secretary, sir.
give a vote of thanks. Secretary, sir, please.
Thank you, Doctor. Thank you, first of all, for inviting me to this wonderful session that has been concluded. MIGS I have learned through webinars. If anybody is over here, I am not a trained glaucoma surgeon, but I have learned MIGS, and I'm doing it through learning through webinars and YouTube videos. So it is totally possible, and you have an additional opportunity. These two guys, Dr. Arshi and Dr. Shivam, have taken a lot of pain to bring this MIGS Sala into fruition. And I think this is a wonderful initiative that is going to happen. And I think I don't see, like not even a single doubt has been left untouched, and everything has been covered. So thank you, Madhavi ma'am, for that wonderful lecture. And I hope to see you all in YOSICon to have a great MIGS journey to start with. And I think I'll just request Dr. Ashi and Dr. Shivam to keep continuing this doubt solving, like informal discussion with doubt solving throughout, so that even when the MIGS, the YOSICon is over, if they have some practical doubt, like connect once or twice in a month
Absolutely.
and
As said, thank you so
keep
much,
guide.
Nilesh. Sorry, I actually lost your audio for a while, but
Okay,
thank
okay.
you so much. A lot of support from our secretary, from all our GC members into making this a success, and I hope that you all make the most of it. Our journey into MIGS starts together. We are actually going to be learning something. Probably a lot of you are doing MIGS. Maybe this is something that's going to be an experience that will enhance your procedures that you're doing, enhance your efficacy, and also add new repertoires and new devices into your MIGS sequence that you have. But also, what I want to tell you is this is just the beginning. A workshop will not tell you everything, but the group that we are created now, you're all going to be together and you can all discuss. It's going to be a very open, safe space for you to discuss your patients, for you to actually seek advice from experts. And this is something that you should cherish. And I hope you make full use of this so that we can all grow together as glaucomatologists. Thank you so much for joining in today, and we will see you at YOSICon. Can you switch on your camera so we can probably have a quick photo, if that's all right? Shivam, anything to add? Madhavi ma'am, anything to add? Nilesh? Yes. Manjula ji, if you're there, can you please do the honors and take a picture for us?
Sure, doctor.
Thank you. And again, a thanks to the Numeraticus team as well for taking care of everything. We're waiting for other people to show their videos. The Yo symbol, please. YOSI. Manjula ji, you can take the picture now.
Yes, doctor.
Used to this people, you're going to have a lot of pictures with this symbol during YOSICon.
Say MIGS. MIGS.
Taken, doctor.
Thank you so much. Thank you, everyone. And for your slots, please make sure to join us at least 10 minutes in advance. We will post exactly where the location is, where your wet lab is, so that you can reach it easily and you are not lost. In case you have any queries, you can post on the group and we will be there to assist you. Thank you so much. Bye.
Thank you, ma'am.
Thank you for
Thank you.
thank you
Thank you so
thank
much.
you all.
Thank you,
Bye.
sir.
Thank you all.
Thank
you so much.
Thank you, everyone.
Wonderful.
Good night. Bye bye.
Manjula ji, we can go off live now. Thank you so much for your help.
Sure, doctor.